all of dentistry, everything we do, not just full arch. I mean, I'm even talking about prophies, cleanings, crowns, root canals, extraction, everything. It's really a form of preventative medicine. It is medicine, right? Dentistry is medicine. We get lost in that. It's like, we go to dental school, we're so focused on the technical skills and you want to learn how to place implants, we want to learn how to do remote anchorage, and it's so heavily skill based because that's also part of our compensation, right? Like we get paid based on procedure, and it's a surgery. Dentistry it's a surgical field. You do procedures, but we often forget that the reason we're doing this is to make people healthier. And it's easy to get lost in that because of the way the systems are built. I mean, obviously dental insurance is separate, medical insurance is separate. And um, I spend a lot of my time thinking about this and how do we bring back that, oral physician and thinking about patients from a physician's lens or from a doctor's lens. All of us are surgeons, right? Like,
welcome back to the All In, All On X podcast, where we take you behind the scenes of full arch dentistry, innovation, and the people who are redefining what's possible. Here we go beyond the procedures and into the lives of people shaping full arch dentistry. This isn't just about implants or workflows. It's about the lives we build, the decisions we make under pressure, and the leaders who push this profession forward when no one's watching. Get your head straight, because we're about to go all in. Before we get into this episode of the All In, All On X pod, I want to talk to you about something that I use with all of my patients, Stella Life. Stella Life is a pre- and post-op recovery system designed around something that every surgical clinician cares about, healing that actually works. Stella Life's award-winning recovery kit supports accelerated healing, non-toxic antimicrobial patient comfort, and provides a natural alternative to opioids and chlorhexidine without the staining, without the unpleasant taste, and without interfering with fibroblast activity. Stella Life is non-toxic, sugar-free, gluten-free, and is manufactured in a GMP facility in the U.S. It's a system trusted by clinicians like myself who give it away to all of my full arch cases. Trust Stella Life. Less opioids, faster healing, happier patients who know you care.
Today's guest is Dr. Shouvik Ponnusamy, the Jaw Doc on Instagram. We'll get into that. He's not just placing implants. He's redesigning the foundation of full arch surgery, business, and dentistry itself. He's a co-creator of the Patsy protocol. A lot of you guys don't know that, with Juan and Dan out there making all that noise on Patsy, but yeah, co-creator of the Patsy protocol. And now you're building I'm going to say a byproduct or a side product or a substitute for dental insurance. I want to jump into that later this hour. And obviously we're going to talk about parenting and kids 101 up front. So, with that, I think this episode is going to challenge everybody and really intrigue everybody. Thanks for being here with your authenticity and your big brain, Dr.
hey,
Jaw Doc.
thanks for having me. Yeah, no, thanks for having me. Always love chatting about full arch and how dentistry, the impact that dentistry makes on individuals' lives. And that's like one of the things that I think is valuable for your audience too, is to always kind of zoom out, and this is kind of the way that I like to think about full arch and really dentistry as a whole. And I love your take on it, which is that all of dentistry, everything we do, not just full arch. I mean, I'm even talking about prophies, cleanings, crowns, root canals, extraction, everything. It's really a form of preventative medicine. It is medicine, right? Dentistry is medicine. We get lost in that. It's like, we go to dental school, we're so focused on the technical skills and you want to learn how to place implants, we want to learn how to do remote anchorage, and it's so heavily skill based because that's also part of our compensation, right? Like we get paid based on procedure, and it's a surgery. Dentistry it's a surgical field. You do procedures, but we often forget that the reason we're doing this is to make people healthier. And it's easy to get lost in that because of the way the systems are built. I mean, obviously dental insurance is separate, medical insurance is separate. And I spend a lot of my time thinking about this and how do we bring back that, oral physician and thinking about patients from a physician's lens or from a doctor's lens. All of us are surgeons, right? Like you can learn the technique. You can learn how to place implants if you practice and get better. You can learn how to do full arch, zygos. I can teach someone who's not a doctor how to do that. But we need to remember that we're doctors and there's a body connected to the mouth. And I think sometimes that gets lost in the way that our education is, not only just in dental school, but even some of like the advanced, courses out there. But I'd love to get your take and, I have some thoughts on that for sure as well.
Yeah, I mean, we're in the same church, I think, on that for sure. It's absolutely correct. I assimilate with you in that dentistry is a part of medicine. And, I'm thankful that it got laughed out of medical halls 100 years ago because we got allowed to, with the whole nitrous oxide experiment and stuff like that. Or dentistry came through as something that was on the back end of a wagon with magicians and circuses. And then, it was voodoo and witchcraft almost through the 1800s. And then you had the whole nitrous oxide experiment that failed miserably at Harvard or Princeton or Boston. I can't remember where, but it was up there in the Northeast, and then just kind of got laughed out of medicine. And I mean, we still are the brunt of all the jokes at all the parties and Christmas parties and gatherings. But it's almost a savior in its own respect because we were allowed to mold this profession without the influence of being like relegated to the bottom rung of the ladder in medicine, and also in enveloped in the insurance debacle of what happened through managed care through the 80s and 90s. And now we're kind of faced with that now, right? Unfortunately, it's like they're coming after dentistry, but it's allowed us to kind of grow and find our own place as physicians of the mouth. But the next 20 or 50 years, the next 10 years, I mean, there's going to be a big swing. And you've got something I want to talk about later in the hour to help uh, bring this back to patient-centered, patient-focused care, where you can actually make a profit and take care of people without the middleman and the insurance company getting in the way, which painfully is what
For
happens in
sure.
managed care. Don't you agree in medicine?
Yeah. Yeah. I think, it's kind of an incentive issue, unfortunately. I mean, if you do go back in the history books, like you commented on, why, dentistry is separate. I mean, it's interesting story. I kind of did a deep dive on this. I started a little Substack blog about kind of bringing back this aspect of the barber surgeon. You heard about that, like how dentists were barbers, and it's interesting. It kind of sounds silly in the modern day, but back in the day, surgeons were basically different than physicians. They were kind of like the ones who were rolling up their sleeves, doing the amputations and the bloodletting and all of the kind of dirty work, so to speak. And your physicians were kind of like the white coat, Ivy League, in their ivory tower, kind of making the decisions. And then the barber surgeon would go out there and hack off the legs and stuff in the war and everything. So what happened was, I think it was like in the 1400s or 1500s, even before the barber surgeons, the priests were the ones who did all the kind of surgery and medicine. The priests were the doctors, really. And one of the popes basically made a big decree in the church, and they said, actually, I don't want priests dealing with blood, and it was like unclean. So they kind of stopped that, and what happened was the next kind of guild or kind of
Did
job
this have
group.
anything to do with the bubonic plague back in the day?
It might have been. I think the bubonic plague might have been a little bit earlier than that, but this is
Okay.
like kind of 1400s, 1500s, where the next kind of guild to pick up all the medicine and the surgery were the barbers, because they were already very skilled with razors, and barbers back then did a lot. They were doing like bloodletting, and they would be cutting off toes and stuff like while you're already there, and and that's kind of how it started. And then eventually, and it was a very prestigious group, by the way. Like these barber surgeons were like surgeons, and like absolutely. And then eventually, what happened is they wanted their own schools because they were more technical and more like procedural. So then eventually that branched off into just focusing on the mouth, and the head, and then it kind of split off into a separate specialty with dentistry. And because of that, we have separate specialties, we have separate payment mechanisms, we have separate incentives. But it's interesting to see how, dentistry really came from surgery, and it really came from this kind of roll your sleeves up attitude, kind of get it done, which I love about dentistry today. Like you mentioned earlier, I mean, the unique thing about dentistry is that we have our own private practices. Like we can critique all day about how, yeah, I mean, being disconnected is not good for many reasons, but it is also good for many reasons because we can do so much in our offices. We can put patients to sleep and do life-changing surgeries that if you try to do some of those things in the hospital, it would take months and months and years even just to get the approvals and to even get the vendors, by the way, if you want to place implants. It's a pain in the butt to do that in the hospital. So it is amazing what we can do, but it's kind of, you win some, you lose some. So now, I think in this day, the advances in what we can do in the office is just insane. It's amazing.
Yeah.
But the
Yeah,
access and, the insurance coverage and whatnot, that's obviously still a big problem, which, requires some significant change, which, that's like my focus now. That's really what we're working on.
for sure. And I mean, look at it, medicine, just some personal, I needed a PICC line once at ASAP. It took me like 8 or 9 days to get scheduled in interventional radiology to get it. My wife needed a big surgery. It took probably 11 months to get pre-approval to get out and get it done. We just had that done, and then,
Mm,
the oversight, you can do whatever you want in your office. I had a complication once where about 6 or 8 years ago, where a staff member dropped a little finger driver down the throat, rested on the epiglottis. I took the patient to the emergency room. I see the emergency room physician there. He's a friend of mine. I see him at the gym already. I said, "Hey, I'm here. I need a chest X-ray. Let's get it." They said, "Okay, there it is." They said, "Okay, let's give her some propofol. Let's get it." He goes, "Can't." 10 years ago, I could have, but now I have to wrap her up in an ambulance and send her to the main hospital for ENT. And, oh my God, it was just like the oversight and the ridiculousness of
Bureaucracy.
the
Yeah, they don't
bureaucracy of
have the
grabbing something
freedom
that
and
takes 7
autonomy.
minutes to get, you know.
Yeah,
And he
yeah.
literally said he hates his job. He like, 20 years ago he could be doing surgery in the ER, and now he writes referrals in a pad and prescribes Motrin. It's you
Yeah,
know,
it's tough. I think it's really tough being a physician now compared to all the different rules and all the control that they have. I mean, just the to comment on prior authorizations now, that kind of arena has gone a little bit haywire, when it comes to delaying care. And there's an interesting discussion. I think there was like a hearing in Congress recently where I forget who it is. One of the congressmen is a physician or a surgeon, and they were talking about how when a third party makes that decision about coverage or authorization that's not based on evidence, but it's just based on contract rules or whatnot, that they should be liable for the medical outcomes that occur from those decisions because this is delaying care. It is causing downstream morbidity, right? I mean, by not approving someone's medication, let's just say that they've been on for 7 years, and now the company changed the formulary and it's different, so now they have to get it reapproved, and that patient might have a asthma exacerbation or something and ends up in the ER. And now, not only did they lose, time from work, they had to be hospitalized and whatnot. Maybe it's an ICU visit. Maybe they're intubated. I mean, you never know. But now they're stuck with, a $30,000 bill. It's like, who's going to pay for that? So these decisions have outcomes, and it's just really, really tricky for us to kind of understand, how is this going to affect the way that we practice dentistry? How can we get more oversight and acknowledgement that dentistry is medicine and that we should have our procedures, like full arch, for example, um, covered under medical insurance. I mean, that's personally what I believe. That's kind of what led me down all of this was honestly my time spent on full arch and seeing these poor patients trying to come up with funds and all the predatory, patient finance situations. I mean, it just kind of, uh, it's sad to see, like, and I get this even without full arch. I mean, we're doing biopsies, we're doing TMJ treatments. I mean, these are, these are very much medical procedures, and the patients are like, okay, so can I submit this to my medical insurance? And I'm like, well, that's a complicated discussion, like we're doing biopsies, we're doing all sorts of medically indicated care, but you try to submit to medical, they're going to say, wait, this is a dentist, this is dental insurance. The dental insurance, of course, is not going to cover it. And it's an incentive issue, when it comes to looking at the incentive. So I like to tell the story. So one of the folks involved with us at Toothsome is Dr. Ed Zuckerberg. He's Mark Zuckerberg's father. And he actually, I mean, he's seen the evolution of, what dental insurance was, when he was practicing in New York, in the 80s and the 90s. He's kind of witnessed this transformation. He's very passionate about what we're doing. And he told me the story about kind of how Velscope, and he's also very involved with kind of dental technology and innovation. And are you familiar with Velscope and the whole like oral cancer screening? It's like I think it's a light It was popular in the GP world. Well, when they were coming, yeah, when they were coming to market, their kind of strategy was like, well, we're going to follow the same playbook that they do in medicine, which is, like, for example, preventative care in medicine, colonoscopies, mammograms, pap smears. I mean, all this stuff is like very well covered by medical insurance because it's preventative care. And, it costs money up front to do all those colonoscopies, but the one out of every, I don't know, 500, 1,000 colonoscopies, you're going to catch a colon cancer. And by doing that, you are catching that cancer early, and you are thus not only extending that patient's life, but because of the early intervention, the intervention it's less costly, because that's from an insurance perspective, it's less costly. So that's what, like, sure, we're going to pay for colonoscopies because it's saving us a lot of money. Basically, that's how they view this. So when you look at Velscope, they're basically, oral cancer detection through a technology, and the idea is that we can detect precancerous lesions or suspicious lesions at a better effectiveness than the naked eye. And, of course, dentists are going to use this because it's an adjunctive tool to help catch lesions. And their strategy was that, hey, we're going to go to the insurance companies and say, hey, just reimburse us for the CDT code for oral cancer screening, which is an individual CDT code. And they were fraught with no success there and difficulty. And they're like, what's going on here? Like, they do it in medicine. Why don't they do it in dentistry? And Dr. Z, he pointed out, he's like, it's interesting because look at what the dynamics are here. If the dental insurance covers this code, what benefit are they getting, right? Because let's say the Velscope catches a suspicious lesion, it's an advanced, dysplasia, or maybe it's a carcinoma in situ or a cancer. What is the treatment for that? That's a surgical treatment, right? If it's a true, squamous cell carcinoma, that's a big surgical treatment. That's going to require a neck dissection, the whole 9 yards. I've done those surgeries, but who pays for that? That falls under the medical insurance, right? The medical insurance are the ones kind of picking up the slack on that payment. So if the medical insurance is going to pay and the dental insurance is really not saving any money by catching that oral cancer screening early, they're saving money for someone else. So why would they cover it, right? And this is that kind of disincentive problem where when you really look at the dental insurance industry and you look at our full arch cases, full arch, in my opinion, is the highest medical impact treatment that exists in dentistry. And you look at the coverage of dental insurance and they cover very well, pro fees and cleanings and kind of the lesser, I'll say, medical impact procedures. Whereas you get into kind of root canals, periosurgery, extractions, implants, the coverage is much, much less. So it's upside down, like when you look at, car insurance, let's say, you insure your car for a catastrophic situation, or your car gets totaled, right? You get into a car accident. Your car insurance doesn't cover the oil changes and the gasoline and kind of the routine, things that you are expected to cover because you are an owner of your car. So in dental insurance, like, they cover these routine exams very well, but they're not covering the catastrophic care. Like, you wake up, cracked tooth, you got to miss a day of work, go get the tooth extracted and get an implant. Like, well, all of a sudden that's like a $7,000 bill, right? It's like, so it's
Right.
opposite, that's what they should be covering most. Anyway,
Yeah.
so I call that the coverage inversion. And I see this most prevalently in full arch. And that's the trickiest thing with dealing with full arch is the payment piece of it.
Yeah. I mean, let's, I want to go with the flow here. Let's keep on talking about this tooth. So so this is, for those that are on YouTube, I got, the toothsome logo, I suppose, up here, powering the direct dentistry care movement. Yeah, I got you at promoting this here somewhere. You're at a trade show.
Yeah, that was like that was a while back, actually.
Yeah. This is what comes up on Google Images when you come up with toothsome in
Wow,
your
really?
name.
Okay.
So
There's been
yeah.
a lot of evolution.
I'm sure. Yeah, let's delve into it because you're about ready to go big time, and I want to get on board and I want you to get this message out there. But um traditional dental insurances, I mean, they just don't work. I mean, I've been fee for service probably what is this year? I mean, I think going on more than 8 years, maybe
Wow.
10, I think fee for service. Um and it's been the best. It's been the best evolution of business, not just business management, but patient management in my practice, because I no longer have to like ask Big Brother if it's okay to do something good for the patient. And what really led me to this was that I had a high end, general implant practice, and I was a Delta Premier provider. I think I had two insurances left, and I'd have patients with full implant coverage, and you would pre-authorize and submit, and it would come back denied, and somebody would say, "Yeah, they have implant coverage, but we feel they're better off with a partial denture or this or that." And then they would write this scathing letter that made me look like a greedy doctor trying to upsell and upcharge. And then it got to the point where they would actually put on the back of that form, "Here are other doctors that you should go see that are," and they were basically doctors that don't have implant coverage. And if the language would insinuate that I'm not a preferred provider when in fact was a Delta preferred provider. And so I'd call them up, and they're like, "No, we're not trying to take away your patients." And and I just went, enough is enough. We're just, if patient needs an implant, we're going to suggest an implant. Later we'll help them file. So we switched fee for service. I never saw like a drop of profit, by the way. I mean, it was, if anything, it went up 10 to 20% that first year. And, we were able to better take care of our patients. And I want to emphasize, this wasn't a purely business decision. This was a patient treatment decision.
Hmm.
I'm tired of seeing patients wait 4 months, get denied, wait another 4 to 12 weeks to get approved, and they just don't get the care they need.
For
And
sure,
so
for
it's really
sure.
very antiquated. So this was built in the 70s and 80s, and it hasn't changed. You're a, so you're going more, let's talk about how Tupin is different. You're going more direct to employers and direct to patients, cutting out the
Y-
middleman. Tell me how that
Yeah,
works.
yeah, exactly. So the idea with, kind of piggybacking off of that discussion about the coverage, insurance kind of coverage, inversion as I call it. I mean, great coverage for like lower cost things, but very not great coverage for higher medical impact things or more expensive things, stuff that patients really need that financial protection for, like dental implants or full arch, for example. But that's kind of the core piece of it is that we're using an insurance chassis structure to finance predictable care. And really, insurance, just from an industry perspective, you take away even healthcare, just insurance as a concept, it's financial protection for catastrophic situations and being able to calculate that risk, right? Like if you look at home insurance, car insurance, I mean, these are, you don't get home insurance to insure your light bulbs, right? So in like primary care, for example, we use, insurance. We want to use health insurance to cover like, the big surgeries and the, infusions and the unexpected accidents and disease situations. But like, should we be using insurance to cover like your annual care visit or like your labs? It's like, okay, well, there's this huge movement in medicine. It's called the direct care movement, where really the goal is to kind of try to separate predictable kind of routine care from insurance and use your employer can still pay for it, but you don't need to kind of submit claims like what are we claiming like for a dental visit, like your routine dental visit. It's not like a disaster happened and now I have to prove I need to claim that this I needed a prophy, and I have to wait for this kind of adjudication process, and some dentist who's like across the country is looking at the x-rays and determining. It's just crazy if you really zoom out and look at it. So that's kind of that process where it's like, okay, we don't need this complex, you know, structure and call center and claims approvals for routine care, for an extraction or something like this. So that's essentially what the direct care movement is. It's growing significantly on the medical side, and we are bringing it to the dentistry side. We don't want to be left behind in this advancement in technology and adoption. So if you look at dental insurance and why it's been so difficult for the dental industry to kind of adapt and to kind of force that evolution, is because the insurance companies have a lot of leverage. They have all of the employers kind of in their pockets, and it's a big ecosystem in the benefits space with benefits brokers and consultants and whatnot. So really, to me, I look at what the efforts that are being done, with the American Dental Association, for example. I mean, we hear like complaints. I see this on Facebook a lot. the ADA is not doing anything, about dental insurance, which is not true, by the way. They are doing a lot of work. It's just the work that they're doing, in my opinion, is a little bit uh, kind of fighting an uphill battle. They're spending their time and resources on lawsuits and litigation, kind of trying to lobby. They're trying to do it
Mhm.
through regulation, but they're up against billion-dollar companies. They're up against folks who are a lot more powerful. So when we see that, the folks are complaining about, ADA not doing anything, I mean, I think the smarter move is to go to where the leverage is, which is the employers. The employers are the companies that 60% of Americans get their healthcare through. They're the ones who actually pay. So if we go directly to employers and say, hey, you actually don't need this complicated insurance product to do your dental benefits, we can have you just have a cash wallet that you can fund and let your employees get whatever they want. If they want to get an implant, go for it. If they want to get, a filling or just go for their cleanings, sure. There's no third party, big brother, like you said, kind of overseeing what care you want to do. Um, it's their money. Let them use it. And that's the concept with what Toothsome's doing. And ultimately, the end goal of this, which is actually how we originally started, was to get these patients who really medically need these dental procedures the coverage that they need. Now, that's kind of how we started with Twosome. I was focusing on full arch. However, that's kind of the end goal of what I want to get to, is to be able to get something like full arch covered by the medical insurance. But there's going to be a stepwise kind of approach to be able to get there. One is simply just creating a dental benefit without insurance that can just be administered directly. And that's happening now on the medical side. And those kind of tailwinds are really kind of helping us with this. But from a doctor perspective, simply just being able to have a discussion with the patient and saying, hey, this is what you've got, this is what we recommend, and not having that friction point where it's like, wait a minute, pause, we got to check your insurance. The insurance company says, no, 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 actually, this isn't covered. And now the patient starts looking at the dentist and is saying, why are you recommending these SRPs and these bone grafts? My insurance company says I don't need it. And it just introduces this mistrust, between now the patient and the provider. And they're like, well, they're saying I don't need it. So are you like scamming me? Or like, it just introduces this ridiculous distrust. And we're trying to bring that trust back into that patient provider relationship where between the only treatment decisions should really be maintained between the patient and the provider. And the way it's paid for is like, here's your money, you do what you want with it. And the employer can pay up to how much they choose. And that's kind of the core concept of it. But you can kind of see the evolution there where if we assume that dentistry is a medical benefit, we can now utilize AI and interoperability, which we can chat about, which is to say that, let's just say you have diabetes as a patient and you have a high A1C, you have diagnosed periodontal disease, and your dentist wants to do some type of periodontal treatment. Normally, that's going to go through prior authorization, submitting an FMX. Some dentist is going to be looking at these FMXs, online and trying to make a decision. Well, now we can say, well, forget all that. This patient, we can pull their ICD-10 code of diabetes. We can pull their A1C. We know that they have diabetes, and we know that the periodontal treatment, granted that it's done and not delayed or not, deferred because it's too expensive. If the periodontal treatment is done, we know that the medical outcomes improve. We know that the A1C goes down. We know that the medical claims go down. So we can, on the spot, kind of point of care, dynamically fund a bundle of whatever treatment that is, bone grafting, SRPs, whatever it is. But the eligibility isn't based on this complex contract, claims, prior authorization. It's API pull to the Epic chart, ICD-10 diagnosis, boom, it's approved, pay for it. Dentist gets paid right away. And that's how this should be done. It's like Uber, like you show up, you already know the price. You get out of the car, you don't even have to take out your credit card. I mean, the first time I got into an Uber, I was like, holy, this is
Yeah.
the way it should be done, and that's what we
Yeah.
want to create in the dental world. If you're going in for a prophy and a cleaning, you should pre-approve that, ping it from your wallet. You go to checkout, you say, hey, yeah, well, see you later. We'll text you for the next,
Yeah.
you don't need to pull
You
out your
do
credit card.
you do the Face ID, click pay.
Done. That's it.
Yeah.
Yeah. Pay
Yeah.
for it even before you show up. Now, that's kind of
Yeah.
the goal here, but you can see the implications of what you can build on top of that, which is these kind of AI-powered dynamically medical bundles, which can not only allow these patients that have chronic health conditions to be able to get the care they need, but it saves the employers money.
This segment is brought to you by JB Dental Lab, your go-to partner for full arch prosthetics, zirconia, PMMA, and digital workflow. With a proprietary portal, in-house designers, and an advanced education center, you will experience reliability, precision, and consistency. Visit jbdentallab.com.
Because now they're actually getting this care and their medical claims go down. And that's why this hasn't really been done before, is because this whole kind of separation and silo of the data, like how our EHRs are all separate. And, I'm a huge nerd for that kind of stuff. So we can certainly go down that direction. But when we have regulation coming down the pipe saying, hey, actually, like hospitals, for example, are required to now put out a public facing Fire API. It's not getting too technical. Basically, developers now and software companies can actually ping medical chart information, granted the patient gives consent, and pull that into the dental office. That's something that we're working on right now, which is to kind of bring in all that medical information to assist you with your workups, your full arch clearances. I mean, you shouldn't have to fax a letter to a physician or a cardiologist. You should just be able to pull the data that you need. If you need to talk to them, that's different. But if you just want to kind of, most of the time, it's just kind of pulling some information. It should be an immediate thing. So it's 2026 and we have all this technology out there and we need to implement this so that we don't fall behind some of these amazing things that are happening in medical. I mean, you just look at full arch, like full arch is amazing. It's just come so far. Remote anchorage, the materials, the prost. I mean, same day double arch treatment. The fact that we can do that is just way ahead of what, a dentist 20 years ago would have ever thought. But then we're still faxing.
Yeah.
But then we're still faxing clearances and we're waiting on fax. We need to kind of catch up. And that's kind of what we're trying to build.
For sure. So this isn't just making dentistry more honest and a better patient relationship. It's making it more accessible probably to patients, that they have that ability to get it. I mean, so is dental insurance patients could still have their dental insurance if they want their cleanings covered and whatnot, right? It's not like going to make it go away. Is dental insurance it's a fundamentally broken forever, outdated, or is there a fix for dental insurance?
Well, I think there's going to be an evolution. I mean, my personal belief is that we're seeing this movement in direct care where a lot of these non-catastrophic healthcare verticals, so primary care is a good example, routine health visits, labs, basic imaging, outpatient imaging is another good one, physical therapy, dentistry, vision. These are all kind of predictable for the most part. I mean, dentistry is a good example. I mean, very little of dentistry needs to be same day, like unless it's like a IND or an infection or airway issue, it's going to typically be going to the emergency room. But most of these types of non-catastrophic care doesn't really require that risk-based financing or kind of an insurance chassis. What we want to kind of relegate the insurance chassis is on the catastrophic care, the big surgeries like, oh my gosh, like appendix is going to burst. We got to take the patient emergency surgery. You can't predict that, right? That's why you have insurance. So there's this whole kind of unraveling of health insurance or unbundling of health insurance that we're seeing now with different companies and employers employing different solutions for primary care, for example, or for even MSK, like in the orthopedic surgery world. Basically, their patient population who needs knee replacements, they're doing it directly through a contract through a surgery center, like a local surgery center with great orthopedic surgeons. And they'll create a bundled price. This is kind of like full arch. Like they'll say, all right, for the knee replacement, for the implant, for the anesthesia, for the facility, everything, it's $20K. That's it. If you do that through your health insurance, it's going to be like 80 or $100K, the actual price. And then the patient out of pocket's going to be higher. So this is kind of what's already happening. And I do think there is a place for dental insurance. And it's going to come into, if the patient does want, that kind of accidental or kind of sudden situation where it's like, man, I cracked a tooth and now all of a sudden I got a $5,000 bill. That is a product that should exist, right? I mean, that should be how the true dental insurance can be administered. But for the routine care, kind of for everybody as a base layer, you should just get your kind of annual, allocation, however much you want. Let's say $1,000, a year or however you want. And you do what you want with it. If you don't use it, let it roll over, let you build it up. And for that rainy day, you do crack a tooth. Well, hey, I got like $5,000 here and maybe my out of pocket's only going to be, $800 or that. You're much more likely to go through with that treatment when the finances are there. So I don't think that dental insurance will not exist. I just think that it's going to evolve significantly over the next 24 to 36 months, just with what we're seeing in the medical side, the AI, introduction of AI and interoperability. I mean, we want to be at the forefront of this, and we're enabling this at scale because it's software. So the goal is that all of our dentists, that are just struggling right now because they're just getting slammed with, limited reimbursements and just lots of friction through their prior authorizations and whatnot. Um, we want to build a path to safety, and I think there's some recent data that came out through the ADA that's saying that the number one problem that dentists in the US are complaining about right now is the insurance reimbursements. So it's literally the number one problem, and we don't have a solution because people don't want to go up against insurance companies. I mean, again, I'm not saying that there's no, insurance is, that there's no place for it. There absolutely is. It's just that we have to evolve somewhat, and let's think smarter, let's think smarter, not harder, and use technology to our advantage.
The barriers to care and payment, and I don't want to get sidetracked on that too much, but I recently saw an article that one insurance company, at least maybe in one state, was going to automatically deny all core buildups, all of them, and make them all have to get justified. And you've got things like that, just these mandates to save money. And you think about the hygiene. I don't have a hygiene department. I mean, I have one hygienist. I've never been a hygiene, but what the hygienists are demanding for wages and their availability and the supply, the supply of hygienists and what they get, and then you come in for a cleaning, someone comes in for a cleaning and they're only going to get paid $34 for the cleaning, and they're going to deny all x-rays, they're going to deny this and that. And dentist collects less than $100 and the hygienist is getting nearly that, and
It's
it's
not
like, how do
sustainable.
you sustain? How do you stay in
Yeah,
business?
it's not,
Unbelievable.
a mom
Yeah,
and pop shop. I mean, I have a practice. I mean, how can you pay your bills? How can you pay your staff? How can you pay yourself, right? Especially
exactly.
the young docs that have a lot of loans. I mean, it's not a sustainable.
I tell families, people say, first of all my patients, I'm an adult only practice. So I just said, you don't need dental insurance. But I'm like, if you have 3 or 4 or 5 kids and your employer is willing to cover a bit of that dental insurance, maybe get it. That's
Yeah.
kind of where my end.
Hmm.
Would you agree? Yeah.
Yeah, yeah. I mean,
So
yeah, if you're, you have kids, I mean, you're going in for your cleanings and fillings, the coverage is pretty good. I don't want to, bash on insurance. Like the coverage is really good for cleanings and for like routine exams, like if you don't really need a lot of interventional care, I'll say, if you don't need a lot of interventional dentistry, like getting in there doing core buildups, root canals, crowns, then yeah, no, it's a great service. But I think probably most of the listeners of your podcast are doing a lot more invasive type of procedures, dental implants, full arch, right? I mean, this is the arena that we play in, right? I mean, this is the area that insurance doesn't really touch, and it just creates a huge gap for us.
by the way, we're also talking to patients on this podcast. I mean, I've only been running this podcast through about 20 some episodes, and I've got people that are finding out this podcast. My patients are listening to this podcast right now. So
Amazing.
it's not just full arch docs. So
Fantastic.
we're
Fantastic.
talking to the general public as well.
I love it.
Uh, yeah, for sure. And that was a really great find. Just actually kind of had another full arch patient come in from this podcast because they're really enjoying it. So
Wow.
um,
Fantastic.
so you're speaking to these people, they're going to hear about this. Let's gosh, I got so many things to ask you. uh First of all, I want to ask you, you might not want to answer this on the airways, and you can politely decline, but if I'm in your board, if I'm sitting on the board at Toothsome, I'm wondering who is gunning for us, who's going to make this difficult for us. I'm thinking insurance companies, DSOs, I don't know, is it politicians, who's in your way?
Yeah. I mean, when you look at any innovative concept or any disruptive idea, there's always going to be entrenched incumbents that are not going to like it because yeah, I mean, like just look at like Uber, for example, like they spent so many years like saying, "Well, actually, no, it's safer. It's actually safer and, more convenient and more affordable to just, to use our product, or like Airbnb, same thing. I mean, anything that's super innovative, you're going to piss somebody off, right? Some kind of incumbent, someone, you're going to change the status quo, like, how dare you, how are you going to change that? So, I mean, that's kind of, any entrenched incumbent that's going to, run the risk of affecting their business, from a direct care model. So there are many layers, by the way, in the dental benefit space and the health benefit space. Um, there's like this amazing, I'll find it and send it to you. There's an amazing, like infographic I remember I saw this is more on the medical RCM side, but how, the money goes from an employer, like you kind of trace the dollar all the way to the doctor. And there was like 17 offshoots of where money goes to the broker and to the repricer and to the carrier and to the TPA. And there's just so many different layers where, like, okay, I'm trying to pay for, like $100 physician's visit. The physician gets like $17. It's like something ridiculous. So all of those mouths to feed, so to speak, are potentially being disrupted now through the direct care space. So, but again, I'm kind of a abundance mindset guy. I mean, we should be using technology and innovative ideas for all of us to grow. And that's kind of why my stance is that, dental insurance, for example, I mean, this is a risk-based financing tool, and there is a place for it in all of healthcare. I mean, there's no question. I mean, we have big gaps in, dental benefits where we don't have great coverage for accidental care or for catastrophic care, especially like in my practice. I mean, we deal with a lot of, accidents and just unexpected things. And if dental insurance could, like what I envision is I think dental insurance is going to pivot into that, like a product like that. They'll adopt a direct contracting layer like what we're doing. I think all dental insurance is going to have like a base kind of direct contracting layer for like their routine care, just like what's happening in primary care. And then they're going to have their like catastrophic layer, like true kind of risk-based actuaries, calculating based on the employer population, et cetera. So I'll say that, the challenges for us are that, right now we are looking into getting a pilot going with a enterprise size employer, like a big company, basically. There's a lot of stuff I can't really share, but basically, we're kind of at the cusp of really demonstrating that this works at scale. Because not only can you kind of remove friction, remove barriers, increase utilization, but it improves medical outcomes, but it also, what the employers care about, the CFO, big, huge company, they care about savings. All of the companies right now in America, these huge companies, they are trying to find ways to save money on healthcare. That's like the biggest problem on everybody's P&L right now. Number one expense is salaries, like staff.
Mhm.
Number two,
People.
healthcare. And that's just number one. So they're all looking in ways, how do we this is crazy. Most of the employers, big companies, they all got hit with, double digit increases in their health claims spend.
Yeah.
So those market forces, when you look at the employers trying to save money, the employees that are just pissed off with trying to navigate this complicated system of like telling them they're not covered, and then the doctors that are leaving networks, you have this kind of, perfect storm, so to speak, of change and adoption. So the biggest challenges for us are just simply getting our message out there to the employers. We've had some really good traction and interest on the provider side, like lots of DSOs, lots of even individual dentists that are already like very interested in this model. But, um, you know, it just takes execution and persistence. I think any great idea, any unique uh, kind of game changing concept, you're going to have to face hardship and you're going to have to be okay with looking kind of silly or looking kind of stupid. I mean, I can't tell you how many calls I've had with benefits leaders, investors, insurance folks. I mean, and they're just like, yeah, this is never going to work. Like, what about the brokers? Or like, what about, it's like, listen, like, you're going to have to be comfortable with that, until you start to see, oh, shoot, like, okay, you have one breakthrough moment and you're like, oh, this actually makes a lot of sense. Like, this is saving money. Like, this is like, okay, cool. Yeah, let's do it. And I think we haven't seen that just because you kind of have to be, a little off your rocker to, to kind of endure all that rejection
Yeah.
and just kind of, lack of momentum. But You know this. I mean, you're an abundance mindset guy. Like if you're passionate about something and, it's not like just a grind, it's not just hard work to you, like you enjoy what you're doing every day,
Yeah.
then hey, I
Yeah.
mean, if I win, I win. If I lose, I still win. It's just like it's a mindset thing. Like I kind of transitioned my kind of vision and mission for what I want to do in dentistry like a couple years back, like kind of a little bit after the Patsy, the authorship of Patsy. I was like, you know what? I I want to transition to how do I impact as many lives as I can? Before it was like, oh, I want to get really good at surgery. I want to just, become like the best full arch surgeon. I still do arches. I love it. It's my favorite procedure, but I want to impact a billion lives. That's what I want to do. Like when I leave this earth, I want to impact a billion transactions onto some that otherwise would not have happened because they would have been, denied. And that's kind of that impact, scale that really, drives me.
No, for sure. Um, there's you got people in your court. You're gonna have businesses that want to save money and they're gonna be incentivized off of you. You got patients that know that this makes sense. They're gonna want to be covered by it. So there's gonna be that phone count. I mean, take it back to Uber. They had a business model that threatened the existing taxi cab companies. And I take it back to like Las Vegas, as an early adopter of Uber, I jumped into a cab in Vegas, whatever, 15 years ago. And the driver was put there in Vegas because they knew they were going to have to get a lawsuit and go to the courts, right? Because the casinos own the taxi cab companies and they don't want Uber there. So they made it impossible to pick up at the casinos and whatnot. And then they kind of made it illegal, sitting in court. So they had to like go looking for a lawsuit. And they did the same thing in New York City, but
Hmm.
now you looked at it and it's just, I mean, it makes sense for everybody. And it's almost as if it is
I,
obvious
I,
there.
I
But
think that,
there was a fight one day, there was a fight there at one point in time, and they were in the
geez.
trenches.
Yeah, yeah. I,
Um,
I
I
think
mean,
the genie's out of the bottle. For healthcare, I guess. For healthcare, it's kind of you see what's happening out there. I mean,
oh yeah,
people are upset.
yeah.
We're talking about prior authorizations getting denied for kids. I don't know if you saw this one viral. This kid with cancer, was denied some, life-saving medicine. I mean, it's getting to like a bubbling over part where now I don't think you can't put the genie back in the bottle now. I mean,
Mhm. No.
consumers, like you go to like a party, people are talking about healthcare and insurance. I mean, I don't think that was the case, 10 years ago. Like people are aware of this. This is something that not only employers, but just consumers and employees are talking about every day. And when something is that pervasive just in day-to-day society, that's when adoption happens. I don't think this could have been done 10 years ago. In fact, there's actually been some attempts. I've talked to some folks of people who have tried to do this actually before, and all of them tell me the same thing. They're like timing is everything. I mean, if you try to do Uber like 20 years ago, like it would have failed. Like if you tried to do any modern like a crypto company, before like 2021 or like before 2017, like no, like it wasn't going to work. So starting new concepts, you need the adoption, but you need timing. Timing needs to kind of align with society and your idea, and we're really kind of seeing that right now.
Yeah. Let's take this. It's been a phenomenal discussion, and I'm not done yet. Doctors that are listening, can I want you to take a minute, and if you could pull up a tab on your to some page and what a doctor's page looks like, maybe talk about this from the individual provider's perspective, or could we talk about this on the corporate level? It would be a great discussion. What is the doctor going to see? What's the patient going to see? Then if you'll pull up a tab, and if it takes a minute, my editor can fast forward. Don't worry. But if you'll pull up a tab, there you see a share button on the bottom,
Hmm.
and you can share a window, and then you can talk about what this looks like on the doctor's perspective from their office.
Yeah, yeah. You know what I'll do instead, Adam, is I'll share the provider tab on the website right now because I'd have to go into like um, we kind of redesigned the profile, so I'll go into the just the website right now because we just redesigned that. It's a little more up to date. Let me actually just share that here.
Yeah, and don't worry about the time. We can fast forward. It's not a big deal.
Oh yeah, okay, here we go. Maybe I even go here. I mean, the idea is that we essentially have a fintech enabled wallet. Every employee has a wallet that is funded by the employer, and we can incentivize use of that incentivize preventative care. So we want to reward folks that are actually going in, getting their cleaning, getting the work that's been done. The employer has agreed to contribute to, we call it like rewards essentially. And this is essentially a virtual card, just sits on your Apple wallet, your iPhone. And what you do is you basically go to any dentist first. You can get whatever care you want. And right now, the model we're working with is kind of on a reimbursement model where you pay for it. Your employer then reimburses you. What we're building now is more like a fintech kind of seamless experience where it's just like, you tap the card and there's no reimbursements, no receipts. So the way it works is the employers, the companies, they fund the wallets. They decide however much they want to fund. The employee then goes to the dentist. They get whatever they want done, kind of up to however much they have in there, where essentially they make their own treatment decisions. There's no kind of third party determining what's allowed, what's not allowed, et cetera, et cetera. And then the dentist, they get paid just like a credit card or like a fee for service patient. They get paid right away. So there's no, claims to submit. There's no insurance verification, prior authorization. I mean, the whole song and dance. I mean, you don't have to deal with denials and appeals. You just get paid right away. So this is essentially kind of checking both buckets where part of the value of a fee for service practice is that you get paid right away. I mean, people talk about getting people to charge your own fees and stuff, but getting paid right away, if you're a business owner and you know what the alternative is actually highly valuable. And then you have the autonomy to do what you like. So essentially, we're working with individual dentists, big groups, DSOs, even entire organized dentistry organizations are now getting involved and interested. Where this kind of idea of autonomy and understanding that if you agree that if you're a practice owner, you're a dentist, if you agree that insurance is really a channel of patient acquisition, I mean, you sign up with insurance, you're going to get patients through your door because you're going to show up on their website, and that's where patients are going to go to say, well, where am I in network? Can I go? I got to go to the dentist. Like, let me go see who's in network. Well, if insurance is bringing you patients in the door, they're doing that because the employer, their employer has contracted with X insurance, who has X network. And if the employer decides, well, I want to use this direct care concept, toothsome, well, now these employees are going to see the toothsome dentist. They're going to say, okay, we're going to go and see these toothsome dentists, and then essentially funnel patients to the toothsome dentist. So you're essentially getting acquisition and you're getting the autonomy. So in my opinion, it's the best of both worlds. Obviously, I'm biased, but this is kind of a way that we can help to improve the friction, which is just the biggest problem, in my opinion, in dental insurance. I mean, a lot of times we complain about the annual maximums not being, changed, since the 70s, basically. And if you ask like insurance folks about that, it's interesting. They'll say, well, if you look at the utilization of that annual maximum, so let's just say typical annual maximum is $1,500. They'll say that only about 4 or 5% of an entire company hits the annual maximum. And you think of that, you're like, whoa, that's like really low. And they're like, yeah, it's really low. So why would we up the max, right? And they're like proud of that. They're like, look, we are killing it. Like the max utilization is so low. The reason why the max utilization is so low isn't because no one's using dentistry. I mean, just look at the study abroad or look at the medical tourism data. Dentistry is the number one service that is consumed outside of the United States. So it's not a demand problem. Okay. There's a high demand for dentistry. It's an access problem. So even though you have dental insurance or you have these benefits, by the time your dentist has to do the insurance verification and find out that there's all these denials, and then the patient gets a surprise bill, the rules and complexities of the contract. I mean, the dentists don't even understand the contracts. It's very complicated to even understand the contracts. The technology, they have to have a vendor stack of like 4 different companies to try to present the treatment in the right way. It's simply the friction that makes it difficult for the patients to actually consume that annual maximum benefit. So that number, in my opinion, is artificially driven down by the complexities. So in this way, you remove the complexities, you can enable the ease of simply receiving care. And it's not like rocket science. It's really it's taking a wall, it's taking money and giving it to people. And this is kind of what happened actually now in the government. I'll stop sharing my screen here, but what's happened recently, which has kind of helped us a lot. I don't know if you've ever heard of uh, ICRA, Adam. Has that sound? It's an abbreviation, ICHRA. But this movement was like the government actually came out and enacted this, which is I think this will be good for your listeners too, just to kind of understand like what's happening on the medical side, which is back when the ACA came out, Affordable Care Act came out, they basically required insurance to, you have to cover, 10 essential health coverage benefits. Dentistry was not one of them, by the way. But basically, you cannot sell health insurance unless you cover XYZ, like primary care, but all this kind of stuff. And what that did was it just made it very difficult for companies to remain ACA compliant, especially like small-ish companies. I forget the cutoff. I think it's like 50 employees, or if you have over 50 employees, you're required to have health insurance coverage, which is very expensive. So a lot of these like small to mid-sized companies are like, oh my gosh, like how are we going to cover this expense? So they started to have to manipulate their employees and saying, okay, we'll have you be working 39 hours a week or something so you don't count towards our full time. So it's very, very difficult. So what the government said, okay, we'll come up with this program called ICRA, which is basically allowing an employer to just give money to the employees. Because normally like a 50 size group employer, in order to give health insurance, it's not as simple as just giving money. You have to have a broker. You have to be able to figure out, what type of plans to offer. It's like a lot of work, and you're trying to figure out what plans your people need. I mean, someone might be having a baby. You might have like a 22-year-old, healthy kid that doesn't really need much. And then you might have like an older person who has like weekly infusions for osteoporosis. Like it's such a wide range. And as like a small company, you're tasked with this behemoth of how do you get health insurance. So ICRA says, hey, you can just give your people money and let them get their own health insurance on the ACA marketplace. And there's like entire companies like dedicated to this kind of navigation. And that concept of just giving them money has really kind of blown up. And we're thinking, why aren't we doing this for dental? Like, why aren't we doing this for vision? Why isn't this happening for every other healthcare benefit that exists? So lots of interesting kind of movements. And the other interesting piece is, besides finance, which we can talk about this, which is that kind of medical, kind of getting back to what we're talking about in the beginning, is that medical dental integration and being able to offer like higher medical impact dentistry, which I think full arch, of course, is number one. Where if you look at like, for example, like any dentistry that we do that can actually contribute to reducing the medical claims of the employer. And I'll give you one example. And this kind of gets to that separation of the physicians and the dentists, because they're not looking in the mouths. They don't have the education that we do. We do a lot of TMD treatments. It's just kind of a nature of, people who are clenching, they crack a tooth, they need an implant. So we'll talk about the implant, but I'm also talking about, helping them with their TMD issues. And, sometimes we have to do arthrocentesis and PRF injections, and we actually have a physical therapist. So it's really kind of holistic, full end-to-end TMD care. But a lot of times there's kind of an airway component to it. And, whether I'm doing a sedation for a wisdom tooth or a implant, the patient is like just needing a lot of intervention for their airway. We'll talk to them like, hey, have you ever got a sleep test before? Like you got TMD, you're clenching at night, you were snoring like a lot during your sedation, and you're really upright. Like, do you snore? And they're like, no, like, I don't think so. Like, I'm not tired, nothing like that. I was like, go get a sleep test. Go get a sleep test. And if we were to send to their physician, and let's just say it's like a BMI 25, slender woman, not big neck circumference, no huge tonsils, like not your classic OSA, sleep apnea patient. Most physicians will be like, I'm not going to get a sleep test on this person. This dentist, like, they don't know anything. Like, why would I even order a sleep test on this? So I use like a particular, Stanford trained sleep physician out here in Austin, but I'll send these patients out, severe sleep apnea, come back with severe sleep. So it's like, this is an example where like on the dental side, you're finding things that the physician may miss. And I was doing the math on this. I mean, you have a young patient that you're diagnosing some medical condition on. Undiagnosed sleep apnea, let's use this example. Undiagnosed sleep apnea costs employers upwards of 50 to 60K a year in emergency room treatments, in undiagnosed chronic morbidity, et cetera, et cetera. And we had them do that by paying for a $200 CBCT scan. It's like, why would the employer not support that screening at the dentist to then get this ROI on the back end and improve the quality of life significantly by catching these things early before it turns into increased risk of cardiac events and stroke and hypertension and really bad bruxism with TMD problems. So this kind of medical dental integration is what I really want to have the greater mission of Toothsome being like, yes, we can fix the financing piece, but I think the opportunity to bring dentistry back onto the medical side is really the goal.
Yeah, because of course, if it comes down to them saving money, they'll be more motivated to let it integrate. I mean, obviously, that's what business is driven by, obviously, the profit margins. So, I mean, you're smart to uh, educate them on why they should be motivated to bring this to light. So if if a person's working in a business, I mean, I imagine they sign up they go to work for a company, they get X number of benefit dollars in year one, maybe it increases with time. Can they hold that into a kitty? Can they hold that into an escrow for future work?
Yeah,
Yeah.
yeah, it rolls over.
Perfect.
Yeah, it rolls over, and it's just so much better that way, and it protects the employer because it's not like an HSA where like the employee, that's the employee's, it's their custodianship. So the employee, when they leave the company, they can go and invest that. They can do whatever they want. With Toothsome, it's the employer's funds. So let's just say someone has $4,000 or $5,000 in their wallet. If they leave, the money actually stays with the employer. So the employer basically can reinvest that. They can pay their people more. I mean, they can decide what to do with all the unused insurance money, which normally just goes out the window. This is just a way to be much more efficient in their P&L for health benefits.
Absolute win-win-win, buddy. I mean, we crushed it on insurance. I think it's I can't. I just glanced at the clock a minute ago. I can't. It's been an hour already. Not that I need to cut you off, but um, you went through
Yeah,
a
I
great
mean,
deal of information. Very,
let's chat
very.
about full arch. I mean, that's what we're huge nerds for. But it's funny, whenever I talk to like
No,
people who are like in my kind of wheelhouse, like we're talking about full arch and whatnot. We sometimes get on like these other topics that like get like pretty like deep into into the weeds and some of these other topics because we just already have so much in common. But yeah, I mean, I'd love to kind of chat about how you know full arch, how like the courses that you guys are doing is like affecting the doctors because I'm noticing kind of a significant increase in interest in these kind of high impact procedures, and it's interesting too because it's not for everybody, of course, but I think for like the really the motivated young docs out there that like understand that like this is like it's like a continuum, like it's a mastery, right? Like you kind of get educated, you go to some cadaver courses, you learn, you always keep, in my opinion, always keep the medical side as the overarching theme. Like you can't ignore, difficult airway cases or, you can't ignore some of these like uncontrolled medical situations. But then you start, doing some surgeries, with a mentor, and really kind of having a mentor. And then you start doing some cases on your own. I mean, that continuum, I think, is really important to impart, I think, on the educational side because the last thing you want to do is like jump in and then you have some, ridiculous case that's like, too difficult to be one of the first cases. But I love to kind of learn about, yeah, I've seen your evolution of all the courses from full arch to pros to business. I'd love to kind of hear about some of the newer courses that I've been seeing that you're posting about.
well, yeah. I mean, and thank you for that. I try not to do this podcast, in a self-serving type, um, you know, for benefit, but obviously it's there for that. It comes across as that, I guess I should say. But yeah, I started teaching. I mean, I've always had a love to share knowledge, and I started to notice a lot of, I'd say, four all on four in my consult bring, and people that really don't understand the concept. And people, would fly to my office and say, "Hey, you're good at this. You should teach." So that's how it all ballooned. And then the hot topic at the time was digital workflow. So we threw a digital workflow class, and then I realized that nobody in the room really knew the basic fundamentals. So I was like, oh, now I need a beginner class. And well, then we need a remote anchorage class. And well, then we need an FP1 class. And then I get inundated with business questions at my clinical classes to the point where if I answer them, I wouldn't have time to teach the clinical. So then we have a business
Separate
class.
course.
So,
Nice.
so that the whole, that what doctors out there, young doctors want, and of course what everybody wants, they want to go somewhere one time, pay very little bit of money, and then go do it. And it's just not the kind of thing you can teach in a weekend. I mean, you're an oral surgeon, 5 years plus or minus of training, and you still come out lacking all on four training. And the idea that someone's going to get educated, by a lab sponsored course in 48 hours or something like that for free is absolutely ridiculous. So I broke it up into so there's 5 classes right now, and probably there could be 6 or 10. But 1, 2, 3, basics, fundamentals, basic cross, basic surgery, analog pickups. 2, digital workflow and advanced prosthetic, concepts. We're going to really delve into it there. And then 3, remote anchorage, and those I let them bundle in a price. And then I've got the business and the FP1 is separate because 5 classes was a lot to put together.
I
But
love
yeah,
that
I think
you have the analog piece in there specifically. I love
we
that
did.
you are not skipping that because in my opinion, like especially for the surgeons, the pros and understanding that will help you troubleshoot down the road. When you're delivering your temporary and you're like, why the heck did I say I can't? Or, something like understanding that.
you know, if you can't, if your implants are properly placed and everything's parallel enough, 10 degrees, 20 degrees, 25 at the most, but you can pick it up. But if you don't do the surgery right, you get your analog is almost impossible. What happens for those that are just digitally minded is they just throw it all in the computer and they fudge it, and these errors they're not additive, they're exponential. And so learning how to do this in an analog, which I think is essential, could make you a better digital clinician. So that's our idea. So
Yeah. Yeah.
everyone
I
should
mean,
know how to pick up the OF1.
yes. Yeah.
When bone is limited, excuses don't cut it. Core Anchorage teaches remote anchorage, zygomatics, pterygoids, advanced fixation strategies for complex full arch cases. Expand your indications, treat more patients, increase predictability. May 15th through the 17th with live surgery and cadaver exercises. Register today.
Yeah. It's interesting because we've kind of been doing a lot of revisions lately. That's just kind of the nature of it. But, I do a good amount of revisions nowadays. But anyway, but the point is that we'll plan the revision, but these are great teaching cases, by the way. But I always try to almost like relive the surgery the first time, and I'm starting to kind of, it's becoming a skill. I'm starting to realize kind of where they maybe went a little awry, because of, like you said, the exponential, errors are reflected exponentially. And I'm curious what you think, Adam. We can chat about this because this is my hypothesis, is that I'm noticing that I'm seeing a lot of failures, prostheses, sometimes single arch ones where there's inadequate posterior restorative space. And sometimes you'll see the lower teeth are just ground down or broken. Sometimes you'll see that the patient never really had bad TMD before, but now the condyles are super, super flat. And I can count probably almost on 2 hands now of the number of revisions I've done, specifically where inadequate posterior alveoloplasty was done. And I'm like, okay, and it might be a timid thing, they're just not going back far enough. And what happens is now the posterior aspect, if you're looking at it from like a sagittal perspective, the occlusal plane is like opposite, like it's like this. And I'm like, okay, if it's like this, there's just not enough room for the mandibular prosthesis. And then you start seeing cracked prostheses because you're overstretching the pterygomasseteric sling. There's VDO issues. They get TMD problems. And I'll go in and this is during the surgery. I'll go, I have to remove the implants, and I'm kind of correcting that posterior alveoplasty, and I'll take a Fox plane and I take a before and after. And I'm just like, okay, and we have people visiting sometimes, like I'm like showing surgeries and stuff. And I'm like, look at how we haven't even placed any implants yet. And all of the time I spent was on like fixing the alveolo and the cant and everything. And like now we can place implants. And like that's kind of the idea where it's like if we're not thinking about it from a prost perspective, like dentures, like you couldn't deliver a denture like that. So if you can't deliver a denture in your setup, then you shouldn't be, you shouldn't place implants on that case.
Yeah. I'm going to share something with you. Because I think you're absolutely right. A lack of alveoloplasty and proper vertical dimensions in condylar CR. That's where it all comes down to. I'm gonna let the cat out of the bag a little bit. I've talked about this in my courses this year, and I've got an article publishing this week in a journal, and
Nice.
I've got a few more articles. It's not a big one, but this was the teaser article, and it's called Influence Magazine. But I've got two other articles they're getting reviewed now for publish. But this posterior space. So when I started doing digital workflow, God, we're probably going to have to divide this podcast into two segments. Let's just keep talking. You got time?
Yeah. Yeah. Yeah, I'm good.
Okay. So I started designing my own arches, going into ExoCAD, whatever, 13, 12, I can't remember 14. And I started playing with that. And Blue Sky plan. I was in Blue Sky Bio at the time, excuse me. And I started doing my smile design, looking where I want my teeth, where do I want my incisal edges at 24, 25? And then I was like, okay, they say you need 15 millimeters of bone reduction. So where is that? And I would go through and I'd plan all that out. I started to notice very specific anatomic bone landmarks that are definitely you can reverse engineer to the smile line. By the way, I've got a concept for this. For those out there listening, I've already filed paperwork for trademarks for service marks on the Vitruvian concept because it's the perfect smile, like Michelangelo's,
Yeah.
Vitruvian man. Here's where it started. If I wanted to show 1 to 2 millimeters of incisal display at 24, 25, where would I cut the bone down? Was always, and if you go 15 millimeters down, plus you allow about 1.5 millimeter for an MUA height of a bone, 2 millimeters is better. 3 is even better, by the way. Get the MUA off the bone if you can. But it's very tight. It's very tough and thin tissue. I started to notice I was always at the top of the metro trigon.
Mm.
16 millimeters, plus or minus 1. And then so I came up with this. You see this line here that if I would, and what do you want the minimum to be? You want the minimum to be 10, better 12 millimeters. Okay. So I would take the anterior descending ramus, the anterior edge of the ramus, and I would draw it down like a ski slope to the top of the middle trigon. And if you can see my cursor here, if the
Mm-hmm.
patient had bone here, this is 4 to 6 millimeters of bone reduction in the molar. It's 6 to 8 in the premolar, and it's 8 to 12 in the anterior.
Mm-hmm.
And these dimensions, just like Michelangelo had dimensions for the head and the feet and the body and the arrow span, they are so unfair and unpredictable.
Mm-hmm.
It's absurd. And I go, where do I do the size of ledge? Here. Where do I cut the bone down? Top of the mental trigon. Okay. And then if I just extrapolate a line there, I've got a bridge that's 12 millimeters in the back and 15 millimeters in the front almost every single time. In fact, I walked into a try-in in my office this week, and first thing I do is I look in and I go, what are the Vitruvian dimensions? And as I looked in at the arch, I saw it was only like 9, 10 millimeters thick in the back. And I instantly said, I probably have a vertical dimension deficiency, right? Because I know unless you don't reduce the bone to the according rules, right? That's the caveat, the bone reduction. I started looking at that case and I ended up, I was right. I had open vertical. But if let's fast forward, and I'm giving people a lot of keys in the, my, let me find something here. So what happened with the maxilla? I'm going to blow this up so everybody can see it. All right. Yeah. Come on. So, oh, it's going to move the line. That's all right. Okay. Let me put it back. All right. So what happened with the maxilla? All right. From where I wanted that incisal edge in the smile design, I want to reduce 15 millimeters. I want a couple millimeters above bone for the MUA height. What happened? I got 16 millimeters. So I did this through probably, I don't know, 300 cases from 2013 to 18. That's when I don't know, that's when I really went full arch only and started doing, 20 or 30 a month. And that's also when I hired a designer. So it took it off my,
Mm-hmm.
my shoulders. But I did all these cases, hundreds of cases, and I was like 16 millimeters to the anterior nasal spine, And then this line was more flat. I would take it back to leave about 5, 6, 7 millimeters behind, the tuberosity. So this one was more flat. This is more like a Frankfurt line. When, of course, when you design your teeth, you want it to be more like a campus line, so you get that nice smile architecture. So I've developed a concept called the Vitruvian concept, and I've got a draft ready to publish and get submitted. But there's pillars to the Vitruvian concept. One, condylar-centric occlusion. And two, proper vertical dimensioning of occlusion. And three, alveoloplasty according to these Vitruvian principles. And what I'm trying to do is incorporate, like, you got your Dawson occlusion, and you got your Spear smile design, and you got your niche fundamentals of, biological, physical prosthetic dentistry. And, excuse me. Can you still see me?
Mm-hmm, mm-hmm.
Okay. I think I switched out my second display just quick for some reason. But anyway, we've got these, I'm trying to incorporate, these different philosophies into one with 4 pillars of the Vitruvian concept to help, doctors kind of gauge how to do the perfect all-line floor without complication, without failure. How do we make the prosthesis thick so the fracture? How do we get the smile line perfect so that it looks balanced proportion according to the face? And, where, and knowing that we have anatomic bone landmarks that will guide us in that direction. So the smile is already, I can stop sharing my screen here, but the smile is always designed according to the face, right? Size of the teeth, the proportions, the midlines, the cant, the frame, the lips, all that. But it's unreal that these bony landmarks are always falling about 16 millimeters from that perfect smile line. And of course, humans are variable, and there's a bell curve. There's probably a 5% outlier on cut ends. So, I mean, have you ever seen something like that, or have you ever heard that?
Yeah, I mean, it's interesting because like you talk about the golden ratio and all these like kind of almost like eerily kind of similarities in like human proportions and whatnot. And no, I'm a big fan of this concept with like Vitruvian, I think it was Da Vinci, basically, like how he was looking at human proportions and geometry, and he was looking for patterns. Yeah, and this is kind of what I always like to, this is totally unnecessary, but we'd always brag about our X-rays. So like, like Juan and Dan, and when I was with those guys, we were just kind of like comparing like symmetry, and just like, it was just kind of an ego thing, to be honest. But I will say, if you talk about biomechanical forces of the human body, there's a reason why the proportions and what Da Vinci was looking at, I don't know how long ago that was, like over, many, many years ago.
500.
Biomechanics follows function. So it's like the joke was that, like we want to get our X-rays like perfectly symmetric because it's just like beautiful, and like it's just kind of like shows off your skill. But think about occlusal forces, and like you do want to have balance, and symmetry, but not only just in a static, like fixed, pose, but in function with like side to side and forward and back. And that's kind of what, when I started thinking about this, about the condyle, because, again, like this, like we're way far beyond what oral surgeons get training. I mean, you learn how to place an implant. I was very fortunate that I was able to place, some zygomatic implants, and we placed the first pterygoid implant actually ever at UIC in Chicago. I had to convince my chairman. I was like, hey, you want to, and he's just like, what? So anyway, but I was very fortunate. But these topics, understanding the prost, and just understanding like how, the measurements stack up, occlusal plane, right? A lot of this, I was able to pick up from the orthognathic surgery workups and orthognathic surgery principles. So I started to look at these cases like manual pickups, for example. Like when I started with Juan, like he was like, hey man, like this is kind of your you have to do this like as a requirement. Like if I go out of town, or if Dr. Emery, our restorative doc, goes out of town, like you need to be able to pick this up. So I was like, yeah, no, cool. Like let me I'll watch you do a few, and let me try it out. And I did a few, and I was like, whoa, this is very educational. Like the way I was learning it and the way I was looking at it, I put on my orthognathic surgery hat, because it's the same principles. And this is kind of a common theme that I teach the residents and the other students I talk to, which is complete denture principles and orthognathic surgery principles are one and the same. And it just has to do with where that incisal edge needs to be, as there's the vertical, the yaw, the cant. So like your aviation, roll, cant, pitch, etc. That you're treating the maxilla or a denture. The maxilla is in the same lane, and where your soft tissues lie over that hard tissue, construct is going to dictate your smile line, your incisal edge, and then everything else has to fall into place. So actually, I've got if you've got time, I realize I know Evan emailed like, oh, if you have anything to share, send it. But I could share this little thing here about Patsy, which is a good example of this concept and
Share that, but I
the
want to
backup.
I want you to share that. But before I forget, you talked about orthognathia surgery. So, this kind of all 2003, I was at general practice residency at Portsmouth Naval Hospital, and it's really like it's called general practice residency, but I'm in the Navy, and it's really like you're working for oral surgery. Like they don't care that there's any other disciplines there, and I love that about it because I love surgery. But they do a lot of orthognathics. They're not a trauma center. They don't even have a gate at the hospital, so no ER. They have a lot of orthognathics. In fact, some other programs would send there from like New York and Miami would send oral surgery residents there to run orthognathics. And I remember listening to these conversations about why orthognathics have relapse or don't have relapse, and why some doctors do and some doctors don't. It's something I picked up there that I forgot for probably 10 or 15 years, and then it came back to hearing these discussions. But there wasn't a lot of talk about the condyle from all of the attendees and residents. Some did, some didn't. And like 10 or 15 years later, I realized that the ones who didn't get relapse were the ones focused on condyles, and the ones who did get relapse. So a lot of my principles that I teach and that I've learned over the years come from the flashbacks I had through orthognathia surgery. And then, of course, through Dawson's books and trainings, things like that, merging all that together with clinician dentistry. So it was interesting that you mentioned orthognathics.
Yeah,
Sure.
yeah, it's definitely a correlation. I found it, by the way. Let me see if I can share this, and I can just kind of go through this real quick, because I think this could be a little mini teaching, little teaching point here for the importance of analog. That's kind of why I'm always about you really kind of understanding the analog. So let me know if you can see this. I've got a full screen now, so I'm not sure if you're still seeing me or if you can see my screen. Okay, well, this
I
is
can
just
see
like
you
actually.
and the screen.
Okay, this is actually just like a little, just kind of introduces, I think, the aspect of Patsy that arguably is the most important, which is future revision planning, or kind of the backup plans. So I think, and just for those of, for the listeners who are not familiar with Patsy, Patsy is basically a full arch implant protocol. It's kind of the universal language, the standardization of full arch, if you will, for remote anchorage. I mean, this is a concept that was published in International Journal Oral and Maxillofacial Implantology in 2023 with myself, Dr. Dan Holtzclaw, Dr. Juan Gonzalez. And the core concept is that it's this implant protocol that allows you to really, even on the fly, have backup plans and kind of have an order of doing your workup to allow you to maintain a graftless procedure, meaning one procedure, immediate load, achieving full arch length, to the first molar or even the second molar, and to really eliminate or minimize your cantilever as much as possible. And this is kind of goes back to when you're first learning about full arch. You kind of learn about different options with, doing bilateral sinus lifts and delaying and staging, 6 axially placed implants versus kind of the all-on-4, concept with angle implants. However, if you have a very severely atrophic maxilla and very anteriorly pneumatized sinuses, your all-on-4 may result in a very short arch length, and I see those quite a lot. A very short arch length or a super long cantilever, and that's kind of where the pterygoid implant comes into play. But basically, it just helps you solve a lot of problems that once you do a lot of arches, you kind of see it's nice to have some standardization there. And it's just basically posterior, anterior, tilted zygomatic implant. I won't spend too much time going through actual Patsy protocol, but I'll give you an example of why having somewhat of kind of standardization or like a universal language for these cases is helpful, because I do a lot, like almost, I would say the majority of my cases nowadays are revisions. And because I'm seeing the way other doctors are placing implants, I'm like, man, if they follow Patsy, this revision will be a whole lot easier. So one quick little case I'll share is, actually it's two quick cases, and I'll make them quick for the sake of time. This is a real patient. This is like when I was still at UIC, that I sneezed out my implant, and I was like, okay, like, I'll take it with a grain of salt. No, she sent me a picture in her hand with the tissue. I was like, oh my goodness. So I'm looking at this, and basically it was a case that was done in the community. It was 2 zygomatic implants and 2 traditional anterior implants. This is kind of actually a well-accepted classification. I think it's a Bedrosian paper where it was kind of showing like zygomatic implants, like different combinations of zygomatic implants based on, complexity and the zones of bone. This is kind of panoramic looked like, 2 anterior implants, 2 zygomatic implants. This anterior one had failed, unfortunately, actually exfoliated through the nasal cavity. But what was interesting is that, as folks in the remote anchorage world know, that in kind of a quad zygomatic implant configuration, there's different ways. They can be parallel, they can be kind of A-frame, as people have different names for it. But generally, the anterior zygomatic implants are engaged in the anterior or superior part of the zygomatic body, like in the circle. And then the back ones are, below that and behind it. But it's not always, standardized. So what happened in this particular case was that the posterior zygomatic implants were engaged in the anterior portion of the zygomatic body. So that's not, how we typically place them. But, it's just, everyone has different styles. So what we had to do is we had to somehow, these were failing anterior implants. We had to be like, okay, we need a backup plan here. We still have we can engage some bone on the inferior aspect of the zygomatic body, but we're going to have to crisscross these implants because the way that they were placed were very kind of intersinus. So we actually had enough kind of extramaxillary bone to be able to do that, which is, this kind of looks a little unconventional, but this was the only way we were able to,
Sure.
Get this patient back. And, we had to kind of get creative here. And this is one of the ways where I'm like, okay, this x-ray is a little unconventional, but if those zygomatic implants were placed kind of in that kind of general guideline, I mean, there were no guidelines, right? Like this is why we're trying to, create guidelines like this, then that anterior, revision would have been a lot more straightforward. And this is kind of your standard zones of bone, premaxilla, premolar area, molar. Arguably, I've seen some papers showing that, you've got now zones, 4 in the zygo, 5 in the pterygoid, and even 6 in the kind of the Z point. With the Patsy protocol, essentially we have kind of different designations in the anatomy, kind of taking that zones of bone concept one step further, where if you look at kind of the posterior, the molar region, traditionally, of course, is very soft bone, and it's I know there's a lot of folks who like don't believe in pterygoid implants, and would rather place like I've heard of this kind of palatal socket of the first molar. But the reality is,
I'm not a fan.
it's like a really short implant in very porous kind of D4 bone. And also too, I mean, you get into the full arch world and you start doing really atrophic cases. I mean, there's just not enough bone to place most of my cases, to be honest, like there's just not enough to do that. So pterygoid implants are a great option, of course. And I'm curious what you think, because I see a lot of kind of hate on pterygoid implants, that they're not necessary. And, if you do an all on 4, like traditional all on 4, like what's wrong with that? And like for me, I'll say, well, if you do an all on 4 and you've got a long cantilever, and let's just say, or maybe you don't even have a long cantilever, maybe it's perfectly fine, but you get one of the implants that fails, well, now you have to put the patient in a denture while you graft and, replace that implant, and to be able to get them back into fix. So it's like, why wouldn't you have a backup plan, or place 5 or 6? So you fail one of them, well, guess what? You can still have the patient in fixed. Anyway, so pterygoid implants I think are great. Starting in the posterior, I won't go through all of this just for the sake of time, but go to the anterior, then do your tilted. If you can't get tilted implants in the premolar area, you then deploy one of three zygomatic implant techniques. And this kind of gets into, once you kind of get into the remote anchorage world, you realize zygomatic implants aren't just putting an implant in the bone. Like getting a zygomatic implant doesn't really mean anything. It needs to be restorable. It not only needs to be restorable, it needs to have longevity, and it needs to preserve bone for the future. So the core concept that I like to talk most about when it comes to the Patsy protocol is that it strategizes saving the anterior aspect of the zygoma for future revisions. And here's kind of just like, I'm going to skip through some of this, but I want to show one case where these are basically just examples of, basically evolved this into a classification system where actually the second paper that came out and
Hey, JB Dental Lab is the lab that full arch clinicians trust when precision truly matters. JB combines advanced digital workflows, photogrammetry compatibility, expert design teams, and high strength zirconia to deliver prosthetics that fit, function, and last. Their communication is top tier. Their turnaround times are reliable. Quality is the reason that so many high volume, all on X practices partner with JB Labs. Visit jbdentallab.com for reliable quality, full arch support. Tell them that the All In, All on X pod sent you.
the Atlas of oral and maxillofacial surgery clinics. That article actually introduced, we could do an entire talk on Patsy, but that one introduced like a staging, almost like a TNM staging for cancer. We did a staging for Patsy, which is helpful for like students that are learning, maybe kind of just getting into Patsy. If you go and actually stage or kind of grade your cases, you might realize like, oh shoot, like this is going to be like a really advanced case. Like maybe I should get a mentor or refer this one out, et cetera, et cetera. So I'll give one example of a revision case here where it's helpful, I think, for all full arch surgeons that when you sit down to look at a case and you're going to do this case, that you want to do the case thinking about what the next surgeon is going to do 20 years down the road. Like whatever you do, especially on the younger patients nowadays, some surgeon is going to look at your work later and be like, okay, how am I going to fix this? Like, so if you can leave some bone, strategically, which is what the Patsy protocol endorses, that it makes it a whole lot easier for the future revision. And some people have asked me, like, they're like, oh, well, like, why are you thinking everything's going to fail? It's like, well, I'm not assuming everything's going to fail. I'm assuming the worst case scenario where that any implant I put into somebody's body could fail. Absolutely.
Yeah.
Just like when you write notes, like I teach this to the residents, like write the note like someone else is going to read it. Like your name is on there. Okay. Like, just like surgery.
I mean, it's not really a pessimistic mindset of why is it going to fail? I mean, like people say, oh, all in four is going to fail. It's going to fail someday. I'm like, well, so is your bridge, so is your veneer, so is your filling, so is your prophy is going to have to get done again in 3 to 6 months. The house you build is going to have to get redone. The tires you put in your car are going to have to be redone. The world, the universe, one of the primary rules of the universe is entropy and dissociation of particles. Like everything's going to fall apart. So it's
like why would you not
good to think
optimize?
this way. You have to.
Yeah. It seems like, to me, it seems like a no-brainer. Like, why would you not optimize for the future? And it's like, no, I'm not planning on this to fail. But in the case that it does, I would rather be thanking myself that I thought about this, So here's just an example of one of the revisions that we did where you can kind of even start to see, even on, this is like a true pan view, but you can, even on the panoramic view here, you can kind of see this like inverted kind of smile here with the prosthesis. And what we were seeing was that the right kind of short implant there, you can't really see it here because of the thickness of the slice, but there was just like a big radiolucency around it. And there had been some previous implant failures. The patient had been in these finals for like 4 or 5 years. A lot of bone had already been, used up, so to speak, with some of these implants. And the lower dentition was just severe bruxism, and the patient was having really bad condylar pain pretty much ever since this restoration was delivered. So we're looking around and we're saying, okay, well, there's some little bit of bone back there for the pterygoids. She's got some bone up here, in this kind of lateral nasal wall. And there's very little bone here. And then, of course, the prosthetic piece, because I'm always, looking at the prosthetic piece. And these are just like slices, just so you can kind of tell, like some of these implants had radiolucency around them. Some of them were integrated, but they've taken up a lot of real estate, of course, which makes it more difficult. But the key finding here is what we were talking about earlier, which is I've just kind of drawn the red line here, which reflects the incisal edge and the occlusal cusps, the occlusal plane, so to speak. And the occlusal plane, for example, like if I was doing orthognathic surgery or if I was doing a complete denture, no one would make a denture with that occlusal plane opposing the mandibular dentition like that, right? So to me, it's like, okay, you can't deliver a final prosthesis if you couldn't deliver a denture. And the same thing with orthognathic. It's like the blue line reflects something that's more appropriate to be a natural kind of occlusal plane, because you can just see how it naturally flows, kind of like that line you were showing against the ramus, I mean, going anteriorly, the mandibular plane angle, the Frankfurt horizontal. I mean, these are all things that I was trained to look at for orthognathic surgery. So I do have a little kind of mini, if you just bear with me, there's a little little orthognathic in here, but it's just so important to illustrate that what happens there. So, and what we see that actually some of these lower teeth are failing over the years. So she had to get these lower teeth taken out because of this early interference, like this inadequate restorative space. That posterior part of the zirconia prosthesis was just destroying that mandibular molar, and she ended up losing those molars. So this is kind of showing you like really where the mandibular occlusal angle is naturally against natural dentition, but because the existing prosthesis was kind of pitched basically posterior down, that's going to cause that early interference and kind of a premature contact there. And a quick little primer on orthognathic surgery here is that when you do, for example, like a Lefort advancement or a BSSO setback, it's kind of, you have to do it in two stages. So first, you can advance the maxilla and you plate it against a splint, and then you do your setback. So there's different way. I won't go too into much details, but basically there's like maxilla first versus mandible first. It's a whole thing. It's on the boards, and it affects the way that the outcomes can go. Basically, your in between step, like if you do the mandible first, you put this splint on, which kind of helps to kind of correct the occlusal plane in the interim before you do your upper jaw surgery. And this is kind of a way that you can stabilize, because you need to stabilize with maxillomandibular fixation, and then you do your plates. So what happens when you do maxilla first? Well, if you do maxilla first, if I go back here, do you see how the middle picture is showing the splint looks like that? Like it's big in the back and small in the front?
Yeah.
But if you do maxilla...
Yeah. As a side, people always ask about doing one arch at a time, and I'm almost always doing the mandible.
See?
Always first. Always.
Yeah. See, you start to kind of think like this because you're starting to notice that all these single arch surgeries, I think the single arch surgeries are the most difficult pickups because you are restricted to the opposing dentition. And this is kind of similar concept in the way that when you do the maxilla first, now your intermediate splint, that blue thing, now it's thick in the anterior. So it's very thick there. And the way that you have to put in maxillomandibular fixation is you put these like wires around the braces. And what happens is you're squeezing the teeth together around this thick splint in the front. And what happens, I think I have a picture of it. Yeah. What happens is now you're creating this lever arm where you're squeezing the teeth together to try to get as much fixation as you can around this thick splint. And what it does is it now kind of pivots the condyles down, and you're now artificially pulling the condyles out of their fossa. And this is what happens when you finish all your plating, you take off the wires, the whole lower jaw sets back, and that's like, oh shoot, we have to replate. It's like a problem in the OR that happens a lot of times with inexperienced orthognathic surgeons. So what we're seeing something. Oh yeah, you know what I mean. Like you take off the wires, set back. You're like, oh geez, we messed up. Then you have to go back in and troubleshoot.
Yeah.
So, and this is all analog, right? Like this is kind of before. Nowadays it's all beautifully. You've got like custom plates and like pre-drilled holes and everything. But without understanding the analog, your fully digital workflow is if you don't understand the steps, you can run into trouble. So that lever arm I was pointing out here about squeezing in the front fulcruming against that splint and then pushing the load down on the condyles, you're seeing the exact same thing. You're seeing forces from the patient trying to bite. They're going to bite so that their teeth come together. That's probably why every time someone checked her occlusion, the teeth came together. Well, she was pivoting against the fulcrum of those back teeth, just getting slammed, and then her condyles were getting displaced out, which is causing TMD problems. So you're essentially creating this kind of lever, forcing those teeth together. Because remember, the condyles are mobile, right? Like you can't just force somebody into an occlusion. The condyles will move a little bit. And if you're not passively getting that kind of CR, you're going to be introducing tissue injury and inflammation into those condyles. So, of course, in this case, we get this stretching of the pterygomasseteric sling. We're going to get increased VDO problems, muscle pain. And this patient was a absolute TMD patient that just was terribly exacerbated since having this restoration. So this poor patient spent all this money, right? Got the surgery done and is now having really, really bad jaw problems and lots of implant failures. And you can actually see some of the early remodeling here. These are just sagittal slices of the condyle with some early osteophyte formation. Anyway, so that I did that exercise where I kind of show the preoperative, the occlusal plane, after the teeth are taken out, and you see it's kind of like a negative pitch or like a posterior down. So after we do our proper alveoloplasty, and remember, I think that the reason why a lot of times people are not doing their proper posterior alveoloplasty is because they're trying to save that bone, that kind of D4, like if you're like that example we used earlier, if you're really trying to bank on that implant in the palatal root of the first molar, you're not going to do that much alveoloplasty because you want to put an implant there. So that can kind of cloud your judgment. It's like you really need to take it down for the prosthetic purposes. Then you can look and see what bone you've got left. So this is just kind of showing that, before and after, kind of correcting the actual occlusal plane, getting all your prost set up before you place a single implant. And then, following the Patsy protocol, we were able to actually do some lateral nasal wall zygomatic implants, pterygoid implants, and get that patient back into a much more favorable occlusal setup where now we start to see that the condyle is able to be in a much more natural, comfortable position during chewing. We actually went back later and did the mandible, and the patient's TMD symptoms have gone essentially to zero.
Yeah.
So that just proves to us, this kind of condyle concept where really the whole theme of all of this is that, we're not treating these patients in a vacuum, like the mouth, the teeth. I mean, it's part of the rest of the body. And I think understanding the prost is so key. And I love that you include the digital. I love that you include the analog in your courses, because a lot of the courses I see, it's all, it's straight up digital. So I don't know the history of this case, but very much it might have been like planned digitally from the beginning. I don't know. But if you're not catching these, analog things, then it's difficult to understand. Like, you're trusting your lab partner, you're trusting the engineer. It's like, if you don't understand it, you're not going to be able to correct the engineer, whoever's designing your case.
Yeah. So many things. That's beautiful that you shared with that. I think, everybody listening to this pod needs to look at YouTube so you can see those slides. And by the way, subscribe on YouTube as well. That there's so much to go into right there. I mean, the person who did it probably wasn't pros trained. They're not thinking about the final prosthetics. They obviously they don't look at the bimaxillary occlusion. They're probably not looking at condyles. And to be sure, I'm positive of it. My module 2 on prosthetics focuses big on the condyles. In fact, I just wrote an article about this. It was in Influence magazine. Also, it's out there October, December, about the importance of the condylar balance and its two-page spread. And I have a longer article getting ready to publish to a journal about that. And this all goes back to the orthodontic training. There was talking about the implant, people don't reduce to save the bone. I see that all the time because they don't know how to put in a pterygoid or a zygote. And the fact of the matter is if you reduce 5-6 millimeters of posterior bone, you're at the level of the maxillary sinus typically. Now you've created an SA4 sinus. And then your implant placement isn't at the molar. It's not the second bicuspid. It's at the first bicuspid or even touching the canine.
Yep.
And your AP spread is only 10-12 millimeters at the most, probably 8 or 10. Then you have a 3-tooth cantilever. So they go, oh my God, I need that bone. And so they put it in that, molar site, and then you're an alveolar bone. I mean, I'm in a rabbit hole here, but metabolically, physically, alveolar bone is not the same as basal bone. It's going to have faster remodeling turnover. It's got more blood supply. It's got less, mineral, it's less dense, and you can't expect it to behave the same over time. And I think back to last year, there was a Facebook post about a dentist who was like, I always put my implant in the palatal socket. And the whole discussion is about whether you can or can't do that. I'm thinking, by the way, let's just talk about that. You're placing an implant into 0.7 millimeters of alveolar bone,
Yeah.
right? Okay, forget about it. But I'm thinking about the alveoloplasty, where it should be. And I'm thinking
Right.
about the
Correct.
condyles. And there's no way to get into that on Facebook. And yet all these
Yeah.
dentists are trying to learn full arch from this Facebook post.
I mean, that's the problem. I mean, like the surgical thing, like going back to the barber surgeon discussion, it's like this full arch surgery, the surgery is the skill, right? The surgery is the execution. That is what you can practice. Like, can you place a first molar implant for full? Yes, you absolutely can. But is it planned in the way that's going to have longevity? Are the occlusal plane mechanics correct? Is the restorative space correct? Like, these are the questions that I like to ask, because when you look at all on four, for example, like classic all on four, four in the interior, it's like, okay, the whole reason all on four, like Paulo Malo, like the whole reason he was doing this was because it was a better alternative than sinus grafting, waiting 6 months, doing 6 axial implants, and then restoring them, right? That was his benefit. That was the delta. He was like, hey, look, I can do this in one treatment, get them into fixed teeth, immediately loaded. This is amazing. But that only makes sense if it's better than the alternative, which is the grafting, the full arch length. So I'll ask, okay, what if you have this serious, sinus pneumatization, where, like you mentioned, your posterior molar is all the way almost touching the canine. Okay, now you're delivering an arch that, if it's got a huge cantilever or it's just a very short arch length, that is not better than sinus grafting. At that point, just do the sinus lift. Do the sinus lift and grafting, because we're all doing all on four, but it's not any better than the alternative. So I think you can't have your cake and eat it too. It's like, if you want to do all on four, you have to do it in the way that it's going to have the same, if not better, outcome than the old school way, right? So it's like, okay, you got to do the right amount of alveoloplasty. You're not going to have enough space. So if you have enough, I mean, this is a hot take, I guess, but if you have enough bone to place an implant in the first molar palatal socket, do you have enough adequate restorative space for longevity? I mean, we'll leave that as an open question.
Yeah. Well, there's FP1 concepts that come into play too, but that's not that simple. I have come to believe, when I started heavy full arch 8 years ago or 10 years ago, it was like, half of these arches I could do standard all on four, and half I'll sinus lift and weight. And the more I've practiced, the more I realize it's like 95% of them should have remote anchor, like a pterygoid, or a sinus lift. So I become this, I don't want to become this doomsday or this gatekeeper of all on four, because young docs, they go, well, I'm not going to pterygoid. You will, but they think they will. And so I say, look, it's fine. Do the lower arch, do a temporary upper denture and a sinus lift, come back and wait, but go learn the pterygoid. But I firmly believe that 90% or better of my arches, they're going to have a two-tooth cantilever, and therefore they should have pterygoid. What are your thoughts?
Yeah. I personally don't like more than like a tooth and a half, if possible. I mean, if you go back to the article that we published, it was essentially, we kind of created this metric called the full arch ratio, which was, if you, it's all about accountability, right? Like, if you're a full arch surgeon, you need to look at your outcomes, like look at not only like your successes, failures of implants, but the prosthetics. So what I did is I went into the lab and I pulled up every single digital design of all of the arches that I did, that Dan did, that Juan did, and we basically created this full arch ratio where any cantilever, well, first of all, I guess for us it was 0 or 2 teeth. Any cantilever that had 1 or 1.5 tooth cantilever was considered like having a cantilever, basically. The other ones were 0. So our full arch ratio, it was like 98% or something like that, because we're doing PATSI. So we really had very minimal cantilever. And I think this is what has really helped the longevity of those cases. And those handful of cases that had them were my cases. They were not Dan or Juan's, because they have 0 cantilever. Every single case has 0 cantilever for them, essentially. That's literally what was in the data. I've seen the data. And we had 100% immediate load rate. When you reduce the cantilever, you're just simply reducing the stress of those angled implants. I mean, it's like, it goes back to the old Scalic biomechanic in Rangert, like those biomechanical studies that really allowed all-on-4 to happen, So it's like, it's not a new concept or anything. If you reduce the cantilever, you're reducing the tensile forces on the angled implants. So why would you not try to reduce that as much as possible? So let alone the other benefits, right, of like having an extra one. So if something fails, at least they can be fixed while you're healing and replacing the implant. So to me, it's like, it just seems like a no-brainer. But again, you have to be open to new concepts. You can't just live in a silo. I mean, there are oral surgeons who will argue with me about like how pterygoid implants are not necessary, and like how, this is like too invasive and stuff. I'm like, that's fine. Like, you do you, man. Like there's nothing wrong with that. Like, I'm not like telling you have to do this. I'm just simply educating for the folks out there who are interested in learning it. It's like, it's again, it comes down to that abundance mindset versus scarcity mindset. People are like, you can't be doing that. Like, that's not right. I'm like, why? Give me one reason. Like, why? Is it just because like, it's not your way of doing it? Because if it's not your way of doing it, that's a you problem. that's not a societal problem.
Yeah, one person jumped on my feeds after posting about pterygoids and said I was doing people a disservice because if they had done a trauma car accident, I was not going to have pterygoid plates. But well, I don't see how many people can benefit from this versus how many people are going to later need a pterygoid plate for some kind of fixation when they're trauma split. I mean, let's look at the incidence and numbers here. I think it needs to be done correctly. I mean, I think it needs to be learned correctly. I mean, there is a danger back there in the pterygoid space. If you know how to do it, you stay within the angles and the lengths of what you should be in. You got a very low likelihood. Of course, you need to know how to manage the bleed, obviously. But if you're doing it safely, you did properly training. That's why, I don't bring people in that I've never met before and let's do surgery and let's do a 2-day class and go to surgery. Let's, it's like, worry about the numbers. Watch us do surgeries, do the typodont, do the cadaver, then go get a mentor, then practice
that
with a mentor.
continuum.
Yes, definitely.
Yeah.
For sure.
And I guess maybe I should, just for the record, like kind of zoom out, like, all of these, remote anchorage in general, you need the proper training. I'm not, by no means am I saying that it's easy. I'm just at this level talking with you, Adam. I'm just kind of under the assumption that we're all, we're kind of doing these cases. But I mean, for the general public, like you absolutely need the training, like you said, just for, not saying it's easy. It's not saying that it's like something you can pick up. You need the training. Just at this level of discussion, I just want to keep that as an assumption. But one other point that I want to comment that you made, which is like the societal impact or the societal benefit. Like, if it's benefiting more people than it's not, then typically it's a more acceptable thing to do, and it's enabling more people to get the care, right? Especially in this area where there's so much misinformation. I mean, patients are going online in Facebook groups. I mean, they're traveling to third world countries. They're traveling all over the place to get this care, and I'm just like, okay, like if you can offer a solution where they are getting good care, you're getting them an immediately loaded prosthesis. These are patients that hate the dentist. They don't even, they don't want to be there any longer than they can. They're not happy with the situation. It's very expensive. Can you just make it a little bit easier for them and not have to do a 6-month bone graft and introduce more complications and, put them on sinus precautions and all sorts of stuff? So, I like to compare that to the whole argument, and we can get into this, about the whole single model, single provider anesthesia, model, right? Which is like, we see every month or so. I mean, some bad incident, unfortunately, happens in a dental office. And the argument always comes up, on social media. It's like, well, like, is this safe? Like, should we, be doing this? Like, should oral surgeons be sedating patients in their office without having a third-party anesthesia provider? And I mean, the safety argument is one aspect, which, by the way, oral maxillofacial surgeons have extensive training. In fact, I had more training than the first year anesthesia residents when we were interns. It's kind of crazy. But anyway, but basically, if you think about it from a societal perspective, I think the perspective that a lot of people don't have is that the ability to do these sedations for extractions and for INDs and just for kind of routine cases that are keeping people out of the hospital, if that ability gets removed, you realize that a lot of patients are not going to be able to tolerate some of these procedures under local anesthesia, or these surgeons are not going to be able to get a CRNA or an anesthesiologist that same day. They're going to have to go to the emergency room. And all of these procedures are going to have to go to the emergency room and get treated in the operating room. And I've actually I was involved in studies about this, about ER visits and non-traumatic dental visits when I was in school. And the cost of any dental treatment in the hospital, like definitive, like operating room, IND, ICU, unfortunately, this does happen. It is so much more expensive and so much more morbid for the patient than if they simply had it handled in the outpatient setting. So from like a societal benefit perspective, that's kind of the mentality that I like to take with these, where it's like, okay, yes, there's risk, and yes, there is, it needs to be handled in the right way with professionals and training. But the opposite, if you didn't have that, could be a whole lot worse for the patients, for the patient care. And us as providers, we're the educated ones. We are trying to guide these patients to make them and give them the information to make the best decision. So if we're talking about, remote anchorage or not, it's like I bring it back to that. Well, if it's better than the alternative from a morbidity perspective, financial perspective, time perspective, then yes, it makes sense. Absolutely. But if not, if you're not going to deliver a prosthesis that is better than sinus lifts, and then do the sinus lifts, and that's okay. As long as the patient understands that's what you're doing, then do it. But what I don't like to see is these all-on-4s that just have massive cantilevers, inadequate alveoplasty, and are, causing problems, because now the patient's worse off. Like they probably have less pain if they're in dentures, and that's kind of the issue that I think we all need to kind of zoom out about.
Yeah. The societal benefit, the masses, being able to impact more people. That's been a general theme this whole time we've been podcasting, and a theme in your life, obviously, it goes outside the walls of this pod. But the insurance, helping them afford better, helping more people afford better care, affecting the billions instead of just affecting the dozens in your practice or the hundreds I got. And then, doing procedures that benefit more people, educating, teaching other doctors how to do it. I mean, I think that you've got a big common theme here, man. I mean, this has been awesome. It's been really great.
For sure, for sure. I mean, we could talk all day about this stuff. It's a super interesting topic. It's obviously we're both very passionate about this, and hopefully, we're able to kind of enlighten some interesting topics for those out there listening. But awesome discussion as always, Adam.
Yeah, for sure. With you as well. I'm gonna let me do this real quick as I get into. Let's just share your page, so people can see where you're at. I think this is you. The Jaw Doc on Instagram, Dr. Samy, Shouvik
Yeah,
Ponnusamy. Yeah, here you
yeah.
are.
Easy way to
Is
get a
this?
hold of me. Yeah, easy way to get a hold of me on Instagram, or I'm very active on LinkedIn too. It's a little bit more on the kind of medical dental integration side of things. I have a Substack called thejawdoc.substack.com, where I have kind of articles about interoperability, medical dental integration, direct care. So depending on kind of your level of interest, there is kind of something for you on the clinical side, or a little bit more if you're interested on the technology side. I am a health tech startup founder, so I'm a huge nerd for AI and all things medical interoperability. So reach out, if you have any questions. Would love to kind of chat. I'm always looking to build with other folks in this space, and I like to align myself with forward-thinking entrepreneur physicians and dentists. So yeah, no, it's awesome discussion today, and would love to kind of continue the discussion as we continue to treat our patients and serve our communities.
Yeah, for sure. Absolutely. With that, I think 2 hours, I think we're going to drop this into two segments. We're going to talk one business with business and insurance. We're going to talk probably one clinical, probably. So, Evan, look for that and put that at the end of the first part, because there's a lot here and I want people to make sure that they have the time to listen to it all on their lunch break. Yeah, Dr. Samy, you and I are going to talk more about toothsome. I think you guys all should get involved with toothsome. Text Dr. Samy about toothsome as well. You and I are going to have more of a discussion offline about this as well soon. If you guys are intrigued by what you guys heard, I'll ask you guys to please subscribe on YouTube and subscribe on your podcast app as well, and share your comments and feedback with us so that we can continue to make this great. But you just heard from Dr. Samy, one of the originators of the PASI protocol, full arch surgeon, and building an awesome dental insurance side product or byproduct to help people afford better care. So with that, thank you, Dr. Samy, for bringing this to us and helping enlighten us and helping to make dentistry more affordable and have better access for the masses and allow the dentist to do the work that we want to do. Thank you, man. I appreciate you
Thanks for
spending the
having
time
me,
with
man.
us.
Appreciate it. Thanks for your time, and you take care.
Got one more thing to ask you. Final four. Are you watching Final Four?
I know Illinois. I haven't been paying attention this year, but getting a lot of texts and emails like, oh, haven't been kept keeping up with it this year.
All right. Well, I gotta go for my alma mater. I'm going for Michigan. So
Okay.
by the time this airs, I'm either going to be right or wrong, but it doesn't matter. Okay. All right.
All right, man. Take
buddy.
care.
I'm gonna stop this and let you have a great rest of your day. All right.
You
Thank
too,
you for
man.
spending some time with us this
Of
morning.
course.
Okay.
My pleasure. Take care. Bye.
Yep.
Hey, if today's conversation resonated with you and you're looking to sharpen not just your technique, but your judgment, your discipline, and your long-term vision, then this is exactly why we built the Atlantic Implant Institute. This is not just some weekend course or module. This is not just some highlight reel. This is not just some collection of disconnected modules. This is the core continuum for education and full arch workflow. It begins with Module 1, Core Bootcamp Fundamentals, where we establish surgical foundations, diagnostic discipline, and repeatable decision-making under real-world pressure. And then it continues with Module 2, Advanced Prosthetics and Full Digital Workflow, where occlusion, vertical dimension, aesthetics, condyles, and execution all converge. And then we have Module 3, which tackles remote anchorage, pterygoids, zygomatics, complex anatomy, taught through biomechanics, planning for predictable outcomes. And after the continuum, we have modules in FP1, fixed immediate load, and also business, how to 5. This is business, leadership, and operational strategy so that you can build surgically what actually works in practical business. If you're ready to go into full arch dentistry with intention, structure, accountability, and purpose, you can learn more at theatlanticImplantInstitute.com.